Thank you so much for allowing me to talk to everyone in the room. My name is Taryn Yates. I am the Health Program Manager for the Idaho Maternal, Infant, and Early Childhood Home Visiting Program. Next slide, please. So I wanted to talk to you a little bit about home visiting, specifically the model Parents as Teachers. There's a brochure that was just put in the chat because Parents as Teachers is the model that's most readily available statewide. So home visiting, many of you have probably heard about it, but for those of you who haven't, it's a long-term relational based program. Families are paired with a designated home visitor. In the case of Parents as Teachers, it's going to be usually some sort of early childhood professional, social worker. Occasionally it is a nurse implementing that model. So home visitors get to know the family over time and tailor the services to meet their need. So basically, in Parents as Teachers, there is no, I'm sorry, there's no gestational age. It will serve a pregnant person or parenting people with children up to 5. The home visiting happens in the home or a location of the family's choice. So sometimes this is a library or a Starbucks or a park or something. That was pretty common during COVID. Generally, families are enrolled in this program for 2 to 3 years. So like I said, it's a long-term relational based program, and there's usually 1 or 2 visits per month for about an hour. So next slide. So this is a slide I like. It's just a nice little, this is what home visiting does, right? This is the crux of home visiting, is to really help build the skills, knowledge, and resilience of the parents. So those parental assets turn into these wonderful parenting outputs that you can see. And that's where you get the strong child outcomes to secure attachment style, positive self-esteem, improved early literacy, social emotional competence, and all that good stuff that we know leads to thriving children. Next slide, please. So how does home visiting help? I really wanted to kind of talk a little bit about how home visiting can help this audience, folks who work with families whose children are perhaps on the spectrum. So home visiting, because it works so much with that early relational health building, you have professionals who are experts in infant and early childhood mental health. Many of our home visitors are actually endorsed. They can help build skills around parenting with difficult behaviors. Also, depending on how young the child is, most parents really start really early with babies. So those early screenings can really identify needs early and then help connect those parents to resources, because navigating the field, especially when you have a child who has particular behaviors, can be really challenging. And also they offer that parental mental health support, because parenting a child who has behaviors who might be on the spectrum, or just parenting in general, can be challenging. So having that mental health support is really key. Lastly, I like home visiting can be a really good referral for people whose children don't quite meet the threshold for more intense interventions. So if they don't quite qualify for ITP, for example, in my case, I have a son who has ADHD and who has sensory issues. And, when he was little and he was biting a lot and spinning around and just didn't sit still. And I didn't really know what to do. I didn't have a home visitor, but I always think, I had a master's degree in social work and I could have benefited from this program. So it's really great support for parents whose children, are having behaviors and have sensory issues and other things, but maybe aren't qualifying for those other behaviors. Next slide, please. So I was really fast. It was basically just to give you like a miniature bomb of information. If you go to the original slide, Lindsay, you can see my email and also refer to, and so I'm happy if anyone wants to reach out to me to ask for further information. I'm definitely around.
Okay, how about that?
Perfect. Yeah, and you can advance to the next slide.
do feel honored to be a part of this talk today. A few little learning objectives. So I'm gonna give a very brief kind of background with autism and genetics, especially with the time we have. It'll be kind of some fast facts with that, as well as what is it that a genetic counselor can do in this process? What sort of most common genetic tests are there for autism, as well as some of the benefits and limitations of genetic testing. You could advance to the next slide. So I'll start with this image here on the right. You might be familiar with at least a version of this. So as we kind of are all really familiar with in terms of autism, there's so many things that are what we see and present with, but also that are experienced by those individuals that we don't often get to see in terms of how we're doing our assessments as well. And especially with autism, we know it's this neurodevelopmental condition. It's complex with these developmental deficits in cognition, language, behavior, and motor skills. It can often impact areas of personal, social, academic, and occupational functioning. It can affect a good portion of our population. So something around 1% of that population have a diagnosis with autism. And then I also wanted to highlight this piece of heritability of autism. So genetics is really just one aspect of the role that it plays within a diagnosis of autism as well. Heritability is referencing what is the contribution or impact of genetics on an autism diagnosis. So not entirely due to genetics, there are still things like environmental factors which play a role within that. And then in terms of what is the actual likelihood that there is a genetic cause that's found in someone with autism, it's kind of lumped in with this other developmental behavioral disorders as well. But this really ranges depending on the study itself, but somewhere around the 1 in 3 children who have autism end up having even a genetic identified cause for that as well. And then I wanted to highlight this piece from the American Academy of Pediatrics. They do recommend genetic testing for all patients with global developmental delay, intellectual disability, and or autism spectrum. So this is really kind of trifold in that same area. It's not necessarily just isolated to autism, but usually much more complex when kiddos have multiple factors going on for them. I will say that as a caveat from our genetics team here, if you're setting referrals for autism level 1, and there isn't other factors kind of going in there, we typically aren't able to accept some referrals in that sense as well. But I'll kind of get into some more details. You can advance to the next slide. So what is it that a genetic counselor does and what do we do? So we have kind of a master's level training in medical genetics. We do training within genetic testing and this sort of short-term counseling. We're not medically trained. We're not the ones prescribing medications or doing these labs. But when we have a family in a room with us, what are we actually doing in those sessions? So first of all, we're doing this assessment. We're trying to assess what are actually the goals of the patient and family. Do they know why they're referred to genetics? What is it they're wanting and hoping to get out of this information? Sometimes it is just information gathering. Maybe families aren't sure why they're seeing genetics and they're just trying to see, okay, is this something that can meet their goals, whether it's something for medication management or even anticipating their child's healthcare needs, or even just answering this question of why does my child have autism as a diagnosis? And then, of course, a big part of this is also just discussion of someone's personal medical history. How does it play a role in that those features of autism or in a genetic diagnosis specifically that has that in conjunction with it? And then we're also assessing family history, kind of in context with that heritability. Sometimes you can see family patterning of this as well. And are there things that we're recognizing, but have we actually identified an actual genetic explanation? And then that third piece there of we actually explain the genetics. So if someone has a diagnosis, what is the factors that play a role? Are there implications for family testing, the actual test itself, making sure families are fully informed for the consent process, as there can be kind of secondary findings, impacts for the full family, reproductive risks within there as well. And then, of course, just education on the diagnosis that's been received. And then this last piece is really just helping families feel not alone in that process. So ideally making sure that they're feeling well resourced with a number of, information, getting them connected with others who might have the same diagnosis, or even just getting them the proper referrals as well for supportive care like you all do as well. Next slide. So let's kind of do a little mock walkthrough of what is it that I talk with patients in terms of these different genetic tests and how they might be different. So this is a slide I actually use really commonly in our clinic, kind of explaining, hey, there are millions of cells in your body. The very center of that cell is where that DNA is located. DNA is just the instruction manual for your body to grow and develop. And what testing does is trying to find, are there these DNA changes that could be an explanation for someone's medical history? And next slide. So this is kind of a little range of what are the types of genetic test results. They fall into about 3 different buckets. So if we're looking on this far right side, we're thinking, yes, if testing came back with a pathogenic or likely pathogenic change, it means there is an identified change, which is a positive result, something that's consistent with the diagnosis that we ideally can change treatment and management for. Can also then go on the far spectrum on this left here with a negative normal result or a typical result. Something that's benign or likely benign is no findings that were kind of identified from that genetic testing. Of course, does it mean that there wasn't something genetic going on? But we kind of talk through that process, especially if we do a tiered approach when we do our genetic testing. And then, of course, you've got these kind of uncertain categories. So right in the middle, where testing is finding some sort of change, we do not treat these kind of as diagnoses for these uncertain changes, but really in our clinic, we're assessing how suspicious are these variants? Can we clarify it with further testing, parental testing, looking at the data that has information about this variant? Is it seen in healthy populations? Does it specifically affect things like a protein product? But ultimately, there are millions of changes and not all of them lead to a health concern as well. Okay, next slide. And I'm going to highlight some of these 4 tests. This is certainly not comprehensive. I'm leaving out quite a few different types of genetic testing, things like metabolic, biochemical, methylation, and condition-specific testing. The first one here I want to highlight are a karyotype or a chromosome analysis. It's sometimes called. The analogy that I often use with families is that, again, this DNA library is what we're looking at. So this karyotype is really this big picture look of your DNA library and saying, are all those books in those shelves? Are there any large chunks of information missing? You can go to that next slide. And this is kind of an image of all of your books nice and neat lined up. This is that karyotype. So on the left here, we've got a karyotype of a typical female, where you've got 1 through 22 all numbered, same men and women on both sides. The difference here is just those sex chromosomes. So for a female, it typically has 2 X chromosomes. And then on the right there, you can see for the sex chromosomes for a male, a typical X and a Y. So for when you're doing a karyotype or chromosome analysis, it often can identify about 2 to 5% of autism cases. And these, again, are these large structural changes. So just a couple of examples that can affect those sex chromosomes in particular. If you might have heard of things like Klinefelter syndrome, where an individual has a karyotype instead of 46 XXY, they have 47 XXY is their karyotype instead of just 1 X and 1 Y chromosome. Klinefelter syndrome can have kind of syndromic effects, which can affect someone's hormone productions, their puberty and development, reproductive health, as well as even having things like a taller stature. But they're also at higher risk for things like developing autism or learning disabilities as part of this too. And then on the flip side, for females, another difference that can be caught with a karyotype is Turner syndrome, where these females will have just 1 X chromosome instead of those 2. And that can also affect things like hormone production, puberty development, and reproductive health, as well as being that higher risk for autism and learning disabilities. These are 2 examples of genetic conditions which are spontaneous. So, genetic doesn't always mean the same thing as inherited. So being able to talk with families about this process, especially as many of them might have this kind of parental guilt with what might be going on with their kiddo as well. Okay, next slide. The next one I'm going to talk about is a chromosome microarray or a SNP array. So again, still using this library analogy, you're looking at these books on that shelf, you're saying, okay, are they all there if that karyotype is all negative? Now we're actually pulling the books off the shelves and seeing, are there any chapters missing, large chapters, extra or missing in that process? Could that actually be an explanation for someone's autism diagnosis? Can transition to the next slide. Perfect. So this is another example of a karyotype. So overall, when we do a karyotype, diagnostic yield specifically for autism, if it's isolated, is around 3%. That yield goes up when there are multiple things going on, such as a combination of global developmental delay, intellectual disability, autism, as well as and or multiple congenital anomalies. That's that diagnostic yield of around 15 to 20%. I wanted to use this one as an example. So DiGeorge syndrome or vilocardiofacial, or sometimes also called 22q11.2 deletion syndrome. So now instead of looking at all of the chromosomes, we're focused on this chromosome 22. You can see you've got 2 copies there. It means that on one of those copies, there's a segment of information, segment of chapters that are missing. So this individual would only have 1 copy of that information. They can end up presenting with kind of a number of different areas in terms of developmental delays, oftentimes a congenital heart defect like a ventricular septal defect or tetralogy of Fallot. They may present with things like cleft palate or bifid uvula, immune deficiencies. They often have kind of characteristic facial features, learning disabilities, or hearing loss. So a lot of different factors there, and about 20% of these individuals then also have autism. So a good context for this is really thinking, if families are, doing testing for autism and they do this sort of testing, we may identify a deletion like 22q that is now an explanation for that autism, but then also has a number of other management concerns that we want to continue to assess for. May not be presenting in this kiddo just at that time, but making sure that now that we know this explanation, are there other kind of low thresholds we have for these referrals? So adding in evaluations for ENT, audiology, imaging for the heart, and making sure that they have these proper referrals as well. And oftentimes we may even do finding things in a kiddo and then even making a diagnosis in a parent. So that's kind of implications that we also kind of consider in our clinic. Next slide. This third test is really specific to a condition called Fragile X. You may be familiar with this. This one has a diagnostic yield of about 1 to 5% for those with autism diagnoses. It's one of the most common known inherited single gene disorders. I often use this analogy of a Jenga tower with our families. So this specific gene or condition is related to a single gene, that the mechanism for it is looking at these different repeats in this gene. And when that repeat level ends up becoming large enough that it becomes too unstable for that gene, families really kind of are able to connect with this idea of, okay, I can see where this becomes unstable and can present with this Fragile X. If you go to the next slide, you can kind of see this range here. So this condition specifically affects the X chromosome and more predominantly affects males in that same way because they have just 1 X chromosome and don't technically have that backup copy like it would for females. So there's kind of 3 main types of results that can happen with this type of testing. They could do that repeat testing and find out that those repeat levels are within a normal or typical range, so under that 44. And then, of course, you can get that positive result when it's over 200, and that could be that explanation for that autism. The other caveat here that's important to note is that when doing this testing, if you get anything within this uncertain gray zone premutation risk, it doesn't provide that explanation for a kiddo's autism or developmental delays, but actually is more of an incidental finding because those are risks for kind of more adult onset, and specifically in that premutation range, as well as kind of reproductive risks. So oftentimes in our clinic, we'll get these genetic counseling only visits where I get to talk with families about what does their result mean? Is it focus in this premutation? What does that present with in adulthood, even though it's not an explanation for the reason they were doing testing such as autism or developmental delay. the condition itself for Fragile X is also syndromic. So of course, kiddos will present with developmental delays early on. They can have intellectual disability. They can often have distinct facial features as a part of this too. And then even into adulthood, will present with things like premature ovarian failure for females, and most often for males, ataxia or tremor. So kind of this uncoordinated movement as well. Next slide. For this last one, I'm going to highlight whole exome sequencing. This one is really distinct in that it's not one that would commonly be ordered in a primary care's office or a clinician office. It's really focused within our geneticist office because it's so focused on being phenotype driven. And it is so comprehensive that it's really important that families do have this informed consent in that process. The diagnostic yield for whole exome sequencing, when we focus just on autism, is around a 6.1%. And again, when we expand it to kind of full neurodevelopmental conditions, kiddos have multiple things going on, that diagnostic yield goes up to about 20%. So it's most informed when we take into factors of not only their history, their presentation, but also the inclusion of parent samples. So it's one of the unique tests compared to these other ones because it's able to include parents, and that really helps with this variant interpretation and making sense in terms of, are we actually more reassured about certain variants because they were inherited from a parent who does not have the same history, compared to something being brand new in a kiddo, even when they fall under these kind of uncertain categories. We, of course, can get information like getting a diagnosis for both a patient as well as their parent as well. All right, and next slide. So now what are kind of these benefits and challenges when it comes to genetic testing? There, of course, is not any one test for every case. And so this is hopefully highlighting a little bit of that, where not each one is going to have the best yield, but depending on each case and depending on their presentation, we often can do this kind of stepwise approach. And then there's also variant interpretation challenge. You know, who is it that we're testing next? Is something falling uncertain? Are we actually suspicious of this? Is there a context that we can help clarify for testing more individuals, testing a healthy individual to see if they have this process as well, in terms of, do they carry that change? Would that actually be more reassuring for us and that patient? There certainly are a limited number of geneticists and genetic counselors, and certainly in Idaho, we're at quite a limitation, and we just have 2 geneticists in the state of Idaho. So that does mean that our wait list can be quite long, and so it can mean a longer diagnostic journey for some families. And that means that, you know, they may have done a lot of testing maybe in the past, or maybe have they had enough time to really think about what their goals are in this process as well. This unexpected result can be a challenge for some families, whether that means, is it a diagnosis for a parent, or maybe families weren't expecting that there would be additional health outcomes they needed to consider as a diagnosis comes out. Other things that can be unexpected are things like non-paternity or non-maternity that we have with testing, especially with including parental samples, as well as even some incidental findings. So things that could have impact for kiddo, but again, weren't originally why we were doing testing. And a piece that I've actually left off here, but that is really important, is kind of this cost and insurance aspect of it in terms of coverage. So it's actually a really handed piece that we do talk about in our sessions, and especially with families, of what is the most effective cost for moving forward, and can we get things covered from that insurance area as well. And on that flip side, for those benefits, so go back one, is again just assessing the goals of the family. Why does, you know, is it for information gathering? Are we answering this question of, why does my child have autism? Maybe it's for IEP support, or being able to have a diagnosis to help open services, things like getting informed with insurance coverage like Katie Beckett, and having this catered for the family. And the other piece here is just making sure that if they're going through our clinic, it's certainly informed and targeted care based off of a diagnosis or changing that management. And then these last two areas of kind of guided resources and research. So making sure that families, again, don't feel alone, that they get targeted areas, or can we make a local family connection here in Idaho? And then for that research piece is connecting them with foundations, or some families are really motivated to contributing towards the research area to be able to shorten that diagnostic journey for others, and better clarifying what is the full spectrum of a condition. And then that last slide. This is kind of geared towards parents, but of course, like if you think your child is autism, talk with your clinician, your doctor, who may evaluate for specialists. For our clinicians, you can always make these referrals. So when in doubt, feel free to send in those referrals to our genetics clinic. We're happy to triage, and we usually send back information and saying, hey, we may recommend this individual to be tested first, or could this be a first-tier test to start with while someone is on the wait list or otherwise. And since there's a limitation of genetic counselors, here's a really handy website from the National Society of Genetic Counselors on how you find one within your area, as well as just a link for the Autism Science Foundation and research. And then the last slide is just my references. Thank you so much.
Oh, thank you. Such an important part of the overall care of autistic children. I think startling to find out where our advances have been in my short career. Well, I guess I should say my long career. Anyway, I'd love to hear any questions. There was one in the chat from Angela Littig about her own daughter reaching a diagnosis of a rare genetic disease after having had a misdiagnosis early on. So again, I think it's in those complex kids we can benefit. Does anyone have any other thoughts or questions?
I have a question, Tom. I love this presentation. What do you say to parents? Like, we went through some genetic testing with my own daughter, and the results were nothing. Like, they found nothing, so there was no reasoning for it. How do you address parents when there's like nothing there? And then my follow-up question is, if that was done early on, like to Angela's question in the chat, do you want to follow up and have genetic testing ever redone, because we're always learning new things? And when would you want to redo it?
Yeah, great question. So I guess to your first question was regarding will you repeat that first part?
Yeah, for parents who get no results.
Oh,
like
yes. Okay.
Nothing that pops up. What do you tell them?
Yeah. In terms of those percentages, in terms of diagnostic yield, it is in some ways pretty small. And I think that some of the families knowing that, hey, there could certainly be something genetic going on. We're just certainly at a limitation with our genetic knowledge. And then it's really just in the context of that kiddo's history at that time. So kind of what to your point of, is there utility in revisiting the testing? Most often we recommend it, especially if there's something new presenting for a kiddo. So now there's regressions, there's developments of seizures that weren't present before. That's really helpful to have, okay, new context. Is there a new area that we haven't actually assessed? And depending on what testing has been done, some labs automatically are reviewing things that are uncertain. If there was a completely negative result, it's not something that's reviewed constantly or multiple times after that. Things like a karyotype, that wouldn't change your results, or things like a CMA, those things are structured. It's when we're getting into this larger whole exome sequencing and someone has had this evaluation already in our genetics clinic, we're following, and especially when something remains in this uncertain category, it's super common to actually revisit this testing in 2-3 years time, and look at that DNA data and say, hey, actually there is new information constantly coming out. This is now a new candidate gene. This is now a new discovery gene that can come through that does actually then come back with a diagnosis. So in terms of when that timing, especially if it's something that is presenting new, I would say that it's most important to get that to the PCP and send in a new referral. We triage those pretty quickly as part of that, and especially with depending on what that is, we'll get those kiddos in to be able to say, hey, yeah, this hasn't been sufficient enough testing, and we are suspicious that something further needs to be looked at as well.
Thank you.
Yes, thank you. I think that is really important. I remember sitting in med school early on when I learned that we would somehow in the next 10 years know the entire human genome. And now look at what we know. So I have a kiddo that has an unknown disease, complex presentation of an adult genetic defect presenting in his child, which normally doesn't. And genetics is just following them every 3 years or so when I can get mom to go in. So I think it's really important to do those follow-ups because we are learning so much more. Elena, you had a question?
Yeah, I just want to clarify. Thanks, Alexandra, for your really awesome presentation. It was really informative. And one thing I wanted to just ask clarification on is the WES that's done, the whole exome sequencing. Is that really if there's like a variant of unknown significance that's present, as we get more information, then you may be able to counsel the family on what that means. But when it comes to the karyotype and the microarray, like we've got that figured out, like there's no new data on that. That's what I'm just trying to clarify for the very basic genetic knowledge that I have. Can you clarify that?
Yes, absolutely. Okay. So we can get uncertain results in all of those categories, aside from probably Fragile X, because we've known when something will expand to the to a next generation as well. But in terms of like things like karyotype or even a microarray, when we see these deletions or duplications, there certainly are a number of them that are still uncertain. And ideally, just again, over time, we'll get them clarified all the way to either pathogenic very clearly or very clearly benign as well. But true for all of them.
Okay, thanks. Appreciate
Thanks,
that.
Alex. Amy, your question?
Yeah, Alexandra, great presentation. Some labs that I've worked with will rerun the microarray sample like after 2 years. How will families know, or even some of our primary providers know, if that's an option? And what do they do to go about making sure that it is done if they want it rerun after 2 years?
Yeah, that is usually lab specific. So sometimes it's just saying, okay, we may preference, okay, what is the coverage for a family? And then, how often is it like almost a patient for life? So I think that in terms of if they're wanting to have it done or recounseled on, I think you can always send in those referrals. Off the top of my head, I don't have those labs that automatically do those, but I know that whenever there is something that does come back uncertain and it does change in classification, most labs will automatically do an addended report. They'll push out a report to the awarding provider to then have them update the family as well.
Great, thank you. And Mike, you had a question? I think this might be our last question due to time.
She answered my question. Thank you.
Can I ask one more thing? So we obviously have a cohort here of individuals who now can diagnose autism within the primary care setting. What are your recommendations as far as their, them ordering tests and, working with the lab more directly while also considering a referral to genetics?
Yeah, great. So I know that at least in the developmental peds space, that you all are absolutely capable of being able to order those whole exome sequencing testing. It's really if you're wanting kind of additional phenotyping that may be helpful with a geneticist, then you can certainly have that in that process. Or even if something is needing kind of a consult, I would certainly default that to Dr. Fleming and Dr. Poscancer for whether they're recommending and saying, hey, actually, I think this kiddo could benefit from being seen in our clinic because it's multidisciplinary, or there is multiple kind of factors that they want to make sure aren't missed in that process too.
Yeah, thank you all. Such a great conversation. I love these intellectual sprinkles, and I think this was more like a cake with fondant icing that says awesome. So anyway, I'll pass it on to Lindsay to wrap us up, and thank you again for your participation, and thank you, ECHO team, for your leadership.
We have 2 minutes. Alexandra, there was one more question that just came in. Do you see that? Then my
Yes.
Okay.
Yeah. So
Gonna take that.
those are 2 first-tiered tests that are recommended that oftentimes are ordered through a primary care office. It's usually based off of the comfort of the PCP, in terms of making sure the families are fully informed, making sure that they're fully consented in that process, because it could certainly mean further testing or, again, reproductive risks. But ultimately, if you're ever questioning and saying, hey, is this something we want to have ordered, you can certainly send those referrals in. Those are certainly common first tier tests that we also do in our clinic.
Thank you so much. What a great day full of information. We are going to meet again next month on the 14th. So March 14th, 12:30 to 2 o'clock Mountain Time. The topic is optimizing support for autistic children, neuropsychological evaluation, and referral strategies. And this is presented by Rebecca Bridges. She is a PsyD and pediatric neuropsychologist at St. Luke's Children's. So we hope to see you on the 14th. If you have any follow-up questions, reach out to myself is probably the best, and we can help get those questions answered. Thank you to all of you for being part of our conversation today. Thank you.